Morning again. We are going to be starting in the next minute or two. So I would like to invite people to take their seats as we prepare to start. Ladies and gentlemen, good morning. I would like to welcome you to this second FATP conference. And the theme is building resilient, sustainable, innovative public health systems through field epidemiology training. My name is Noella Bigirimana. I work at the Rwanda Biomedical Center, and I am pleased to be a facilitator for today. I would like to welcome our guest of honors today. We have the Honorable Minister of Health, Dr. Daniel Ngamije. We also have His Excellency, the U.S. Ambassador, Peter Vrooman. We also have among us the University of Rwanda Vice Chancellor, Professor Alexandre Ryambabaje. We have Dr. Simon Atala with us today, who is the AFNET Executive Director. We are pleased to also be joined by the Director General of the Rwanda Biomedical Center, Dr. Sabin Sanzimana. And I want to acknowledge also the presence of our key partner and represented by representative of the CDC here in Rwanda, Dr. Thierry Rose. I want to acknowledge many of our partners here with us, FATP trainees, and many others that are joining us today in the room and also virtually, because we're having a virtual conference today. And so we'll have interactions throughout the day, both in this room, but also some engagement because we are live on YouTube, but we also have another virtual platform that people will be able to participate in. So without waiting any longer, we are very, very happy to have reached today, where we are celebrating the 10th year anniversary of the field epidemiology training program. And as I look around the room, I know that many have gone through that program, or have partnered, or have mentored, and have contributed in many ways. And so we are very honored to have you join us today. So to begin the program, we will be having a video that will kind of give us an overview of the FATP program. And so we have 4 screens around the room, and that we'll be able to use for that video. So please go ahead.
They answer many questions and solve many questions. It's been gratifying to see the trainees transform student profession. Problems and what's that in itself.
Please join me in acknowledging what this program has been able to do, because like they're saying in the video, I have to say here that I'm not trained. I wish I were trained by the FATP program, but I'm a proud mentor. Because as I learned about the program and what it offers, I was very, very willing to be associated with it. So I want to take this moment to acknowledge just the impact it has had, because for a program to, to have been able to provide frontliners, managers, policymakers who have been affiliated to this amazing organization is something huge. We talk about 10 years, but you can quantify 10 years and look at the value, look at the scale, and look at the impact this has had. I have colleagues that have gone through this program, and I always say that you can tell who has been trained, because it's intensive. It takes you through the learning by doing is truly by doing, because as they are working alongside you, they are going through some quite intensive training. And so there's no better time than the current times we're going through, not better in that way, but in seeing and acknowledging the value of the FATP program, because we are in the midst of a pandemic, and we've seen what these disease detectives and, from the first cohort to the sixth cohort, they've come along the way. They've come along the way, and they've been true assets to the response. And the partners that have joined have just done an amazing and tremendous job in being able to show and sort of gain this value. So it is my absolute pleasure to be in this room and joining and playing a small part in this event. And so next, I would like to invite the Director General of the Rwanda Biomedical Center, Dr. Sabin Sanzimana, to share a few remarks with us.
Thank you, Noella. Good morning, everyone. Honorable Minister, Excellency Ambassador, the Vice Chancellor, Dr. Simon, all researchers, leaders, friends, my colleagues in this room. It's my great pleasure to welcome you in this conference. I've been working with the different technical committees to host this first face-to-face conference after almost 2 years working online with a lot of webinars and online communications. So when field epidemiologists do their job, we can come back in this room. This is the first thing I want to highlight. And when I was working with the team on this program, I said I don't have a speech to make because I've been using slides almost every day in my last 15 years as a doctor, as an epidemiologist. So I tried to make a few slides to put in this few moments in the context. And if the slides are ready, just 3 or 4, I can go through and let the event begin. Thank you. I hope everyone can see the slides. So I tried to think back in the history of epidemiology and medicine, which is our next slide, and see what are the changes that happened over time. Probably those who have had epidemiology courses will remember the last on this slide, the last person, John Snow, who has done some tremendous change in what we see today as epidemiology in observation, and how by just thinking and observing things we can save a lot of lives. And this is not just from 1747. It has started even before. In Egypt, for example, when malaria was not yet known, and people could just detect and manage malaria by that time, before Jesus Christ's time. And today, we've seen a lot of changes in the history of medicine and epidemiology. And maybe I'll focus on John Snow's work because it's most recent, not very recent, of course, which is the next slide. John Snow, for those who have not had this this class, he has made changes when cholera in London was taking a lot of lives in 1854. So by just changing water taps, he was able to stop this other epidemic. Now, today, we are no longer talking about cholera, which is not yet over, but we are talking about other pandemics. And a serious one, which is still happening, is COVID-19. So FLTP started in 2010 with the first cohort here in Rwanda. I was happy to observe the beginning of FLTP in Rwanda with the first cohort 2010, 2012, 2014, 16. And today we've seen a number of FLTP trainees have become leaders, have become mentors, who are now teachers, more than 600. And they are not only in Kigali or outside Rwanda, which is also okay, but they are serving in all districts of Rwanda, as you can see on this map. Some are advanced level and frontliners. Others are in advanced category, others are on the front line, others still in training. But this program has been a success over the years. On the next slide, I want just to see, to bring this importance of the training in the achievement we've had in COVID times. First, in the essential public health activities that these people have contributed to, but the infrastructure they have helped to create and to put in place, such as health system, the financing, the services that have improved through guidelines and policies they contributed to, but also making sure the services are going to the people. There's no doubt that the health workforce is the key driver of the change in disease prevention and control. And when community trust is there, it's always better. Could you go back to the first slide, please? We are still on the previous slide. Thank you. And I want also to highlight on the left side of this graph, the importance of information technology and data to make sure there's a resilient health systems. But more importantly, on the right side of this graph, the global health security agenda, quite important, and the collaboration, the external partnerships and internal partnerships, integration, thus bring all of us through the theme of today, which is the best theme we can think about in the middle of pandemic like COVID, building resilient, sustainable, innovative public health systems. So my last slide is on what these people have contributed to in just one simple snapshot. They went on field in different districts, at the islands, in the water, in the air, everywhere. These FLTP trainees have done a great job. They have helped to detect early COVID-19 and to even control it using a lot of technology and innovations. And today, we can enjoy the data that are coming every evening. We can enjoy to meet together safely in this room, the diagnostics, the vaccine that are being deployed because of the success of these trainees. Their trainers, the partners who have worked behind, the University of Rwanda, CDC, ARFANET, USAID, WHO. There are many actors, just to name a few. This is just an example on how training a capable workforce and people at different levels with great mentors can be the best investment in our time and in the future for future generations. So with this, I would like to pause my slides and just thank everyone, especially our guests today. The Honorable Minister is very busy. I know the Ambassador also has a lot on his agenda, Vice Chancellor. The Director of ARFANET who traveled long distance to join us and the team, the colleagues, the teachers, the professors who are in this room. Welcome everyone. On behalf of RBC, we are very happy to be a partner in this program and we will continue. Murakoze cyane. Merci beaucoup.
Thank you very much to the Director General. I think he's just put in context what this program means. Allow me to welcome next the Vice Chancellor of the University of Rwanda, Professor Alexandre Ryambabaje, so that he can share his remark with us today. Welcome, sir.
Honorable Dr. Ngamije, Minister of Health of the Republic of Rwanda, Your Excellency Ruman, Ambassador of the United States of America to Rwanda, Director of the Africa Field Epidemiology Network, Director General of Rwanda Biomedical Center, senior government officials, distinguished participants, all protocols observed. Ladies and gentlemen, good morning. Distinguished participants, allow me first to recognize here in the room Dr. Jean Kagwiza, Principal of the College of Medicine and Health Sciences at University of Rwanda. Recognize colleagues, faculty or academic staff, under the leadership of Professor Ntaganira in epidemiology and the leader of FETP. And also acknowledge the presence of alumni of this program. A number of them we have been working together while I was teaching biostatistics in the program, and also acknowledge the presence of students who are still in the program. Distinguished participants, thanks to the leadership of academic staff at University of Rwanda and the commitment of the students who were enrolled in this program, the University of Rwanda has been the largest contributor to workforce capacity building and development in the quest to better serve the population of Rwanda through quality education. As we know, from the COVID-19 pandemic, public health emergencies that are complex involve a wide range of sectors, to the extent that today we are talking about One Health that involves human beings, animals, environment, etc. And they have an impact on many different aspects of people's lives. So in order to effectively deal with these public health threats, competent human resources need to be trained and effectively deployed to ensure a comprehensive and coordinated response. Through the work of FETP residents and graduates, we will have on display the impact of training disease detectives who foster applications of epidemiologic methods to a wide range of contemporary public health problems. Our institution, University of Rwanda, through the School of Public Health, is at the front line in responding to COVID-19 pandemic and other emerging and re-emerging pandemic threats in Rwanda. Under the flagship of the Field Epidemiology Training Program, which we are celebrating 10 years anniversary. Research is seeing what everybody else has seen. But researchers think about what nobody else has thought. And this scientific conference serves as an opportunity for residents and graduates to introduce and present their works and connect with each other so that they can share scientific knowledge. However, and most important, the end goal is to ensure that relevant research findings lead to evidence-based public health actions that have the potential benefit to society. I therefore commend the Ministry of Health, through you, Honorable Minister, for the coordinated collaboration and continued collaboration and support for the FETP program. As the main recipient of graduates that you have equipped with skills and knowledge to serve with professionalism. We at University of Rwanda are glad to have played a role in the advanced FETP, providing the academic assurance and quality which has allowed the program to mature and deliver to the expectations, if not more. The University of Rwanda is grateful to the Ministry of Health, the US Centers for Disease Control and Prevention, CDC, and I would like to thank the Director of CDC Rwanda for his presence here today, and the African Field Epidemiology Network, AFNET, who is represented by the eminent continental leader of the program. So we would like really to thank you sincerely for the continued collaboration and support since the inception of the program in 2009. Distinguished participants, ladies and gentlemen, I would like to thank all the participants to this meeting and wish to all the presenters an excellent scientific conference filled with insights and inspiration. I thank you for your kind attention.
Thank you very much to the Vice Chancellor who, and I want to join him in acknowledging again the faculty, the alumni, the students in the room today, because we've seen that you are an invaluable partner. We've seen service and how you have built a capable workforce where skills meets passion, meets impact, and we've really those have been displayed in this COVID-19 response. I would like to now welcome another invaluable partner, the director of the AFNET, Dr. Simon Atala, to share with us his remarks. Welcome, sir.
The Honorable Minister of Health, Excellency, the U.S. Ambassador, the Vice Chancellor, University of Rwanda, the Director General, Rwanda Biomedical Center, the Country Director, CDC, and all other partners present, faculty, graduates, and residents of the Rwanda FETP. Ladies and gentlemen, I bring you greetings from the Secretariat of the African Field Epidemiology Network, AFNET. We thank you for the opportunity to make a few remarks at this occasion. It cannot be overemphasized how excited I am to be part of this conference. I had the privilege to be part of the team that worked to establish the Rwanda FETP. With funding from the US CDC, the African Field Epidemiology Network, I was hired as the first resident advisor to come to Rwanda to support the setting up of the Rwanda Field Epidemiology Training Program. I arrived here in December 2008, and in 2009, we conducted 2 short courses, developed the curriculum for the advanced program, and had the needed engagements for its launch. In 2010, the advanced program was launched with the residents of the first cohort taken from national level. I left here in 2012. I am glad to observe how the program has grown over the years, and I congratulate the leadership of the program for this feat. The role of Rwanda FETP in public health workforce development and in public health interventions are well known. The program is producing competent professionals who are translating the knowledge and skills acquired during the training into various critical public health services, and by so doing, contributing to national creating a platform such as the Rwanda FETP Scientific Conference to share the good work that the program is doing is commendable. The COVID-19 pandemic emphasizes yet again the need for a competent public health workforce. The critical roles that field epidemiologists are playing in all pillars of the pandemic response justifies the investment in developing this capacity. Pandemics are not just public health emergencies. They are political, economic, social, and security emergencies. And the work of the field epidemiologists contribute to mitigating them. The ability to respond promptly determines the level of mitigation. Prompt response in turn depends on the availability of resources, including a competent public health workforce imbued with the right knowledge, the right skills, and the right attitudes. In a video recorded speech to the 10th Definite Global Dr. Tedros succinctly captured the relevance of FETPs when he said, and I quote, "The relevance of FETP and the need for trained field epidemiologists could not be greater. Every member state needs a strong field epidemiology workforce working with communities on the ground," unquote. FETP is one of the greatest gifts to the world when it comes to public health workforce development, and by extension, health system strengthening. The thinking behind it is one of the most profound in public health strategy. We owe it as a duty to nurture, grow, and sustain these programs. The IHR Joint External Evaluation report is replete with findings that indicates that many African countries have not met the Global Health Security Agenda minimum targets of 1 field epidemiologist per 200,000 population. The deficit in field epidemiologists has implications for public health emergency response. Africa needs a revolutionary approach at expanding field epidemiology capacity development to generate a critical mass of field epidemiologists before the next pandemic. Permit me to touch briefly on 3 issues that constantly occupy the minds of all concerned with field epidemiology capacity development. One is quality of the program. It cannot be overemphasized that continuous quality improvement is key to maintaining the relevance of the program. A high quality program that is contributing meaningfully to the national, continental, and global public health agenda is one that is highly desired and likely to attract the needed resources to guarantee its longevity. The definite accreditation and the Happiness Star rating system are designed to support continuous quality improvement of FETPs. And I urge you to make the best use of these platforms. No doubt that the Rwanda FETP is doing a lot of quality work and producing quality graduates, some of which are supporting FETP training in other countries. I know a number of them are also in international organizations. But as you know, the room for improvement is never full. The second issue is sustainability. The critical role that FETPs play in public health workforce development, and for that matter, in the provision of critical public health services, is universally acknowledged. But many countries are not walking the talk in terms of the investment being made to ensure the sustainability of their programs. I am aware of Rwanda's exemplary efforts at integrating and sustaining the program, and I have no doubt that these efforts will continue. Sustainability is important, but equally important is the issue of career path. Providing opportunities for FETP graduates to translate the knowledge and skills they acquire into critical public health services is the only way to reap the dividends of the huge investment in their training. The need for a resilient workforce is critical, but equally critical is defining clearly how to utilize this workforce. It is therefore very important to address the question, after graduation, what next? To all the partners in this room, and to the USCDC in particular, who have been working with us to support the Rwanda FETP and all the other FETPs that are in Sub-Saharan Africa. We have 16 advanced programs, 25 frontline, and 10 intermediate programs. And all these programs, we have partnered with the USCDC to establish them. So I want to tell you, we thank you very much for the partnership, and we are we are grateful for all the collaboration. You have been doing very well in providing this support, and we thank you very much. But again, I want to say that the room for improvement is never full. To those of you whose work have been accepted for presentation, congratulations. Mark Pendergrass, in his book, Inside the Outbreaks, described the parable of two doctors who on a particular day went to enjoy their lunch at the river bank. Referred to as the Brown River, it usually flowed lazily through the middle of the town. But on this particular day, this river was flowing in torrents and carrying human bodies. Some were still alive, gasping for air and trashing the water. Out of the water. There was no sign of violence, but the victims had glazed eyes and racing weak pulses. The doctors could not keep up with the flow of the bodies. They saved a few and watched helplessly as the others drifted past them. Suddenly, one of the two doctors lowered an old man to the ground and started running. "What are you doing?" yelled the doctor. "For God's sake, help me save these people." Without stopping, the doctor who was running away yelled back, "I am going upstream to find out why they are falling in. I am going upstream to find out why they are falling in." Ladies and gentlemen, running upstream to find out why we are having a particular situation and to use that as the basis for intervention, that is field epidemiology. That is providing evidence for decision making. The use of evidence is extremely important for effecting a valid, effective, and efficient public health response. As field epidemiologists, you are sentenced to a lifetime of running upstream to find out why we have problems or why things are happening and providing the evidence to guide decision making. This is a good sentence. From today to Friday, you will be sharing with us what you have been finding out anytime you run upstream. In making your presentations, you will be developing your competence in scientific communication and fulfilling a requirement, a training requirement. More importantly, you will be sharing information that would inure to the benefit of public health decisions. May I also say a word or two about safety during this difficult period? There was a judge in the US called Benjamin Nathan Cardozo who said something I find very profound, something that relates to our circumstances. He said, and I quote, "Danger invites rescue to the victim and to the rescuer," unquote. Danger invites rescue to the victim and to the rescuer. Ladies and gentlemen, this is not a call to fear. This is a caution call. As we work to rescue many from COVID-19, we must take note that in our positions as rescuers, we also need rescue. We must therefore take all the necessary precautions to ensure that we protect ourselves, our families, and our communities from COVID-19. This includes distancing, masking, sanitizing, but also very important, it includes taking your vaccines. And not only you, we need to help others to understand the value of these vaccines. I wish all of us a very exciting conference. Thank you.
Thank you very much. I want to thank again Dr. Atala. As he just mentioned, he was the first resident advisor back in 2008, and he has seen the growth and nurturing that this program and how far we have come since then. And no doubt that these investments have shown substantial dividends. And from the right knowledge to the right skills, and he mentioned how we continue to grow and improve in terms of quality, sustainability, and career path. So may we be reminded to always run upstream and find the root cause, and so that we can inform the decisions. I'm now honored to welcome His Excellency, the U.S. Ambassador, Mr. Peter Vrooman, for your remark. Welcome, sir.
Thank you very much, Noella. Honorable Minister Daniel Ngamije, Dr. Simon Antora from AFNet, Dr. Savin, Director General of RBC, Dr. Terry Rolls from CDC, for joining us here today. I would also like to welcome all disease detectives in the house. How many of you are disease detectives? Please raise your hand. Fantastic. Let's hear a round of applause for the disease detectives. On behalf of the US government and the entire team from the Embassy of the in Rwanda, it is my pleasure to join all of you for the second Rwanda Field Epidemiology Training Program, FETP, Scientific Conference. And I'd like to take a moment just to recognize Jared Omolo. Please raise your hand. Jared is our current resident advisor and has really contributed to all the teamwork here in training these generations of disease detectives. I would like to thank the Ministry of Health, its partners, and the organizing team for convening this conference in order to celebrate here in this room and online the progress that Rwanda continues to make in public health, specifically in workforce development through Field Epidemiology Training Program. We have the chance to hear the great work of faculty, mentors, the 26 trainees and 53 graduates, and to reflect on the lessons learned from running upstream and the partnerships that have allowed our work to flourish. The United States is committed to working with the people and government of Rwanda to improve health and to fight disease here in Rwanda. And even this evening, we're welcoming some 300,000 doses of Pfizer vaccine and another 400,000 next week to help with the effort to fight the pandemic and to contribute to Rwanda's terrific health response to COVID-19. But I would say that that is a material contribution to fighting disease. And unless there is the scientific mindset that my previous panelists have mentioned, it will be very difficult to utilize those vaccines as effectively as possible. Here in Rwanda, the government of Rwanda and the government of the United States, through CDC, through PEPFAR, the President's Malaria Initiative, have provided more than $10 million in direct support to field epidemiology training since its inception 10 years ago. I want to pause before I continue my remarks to just to share something that I picked up on from Dr. Sabin's presentation. He mentioned one of the great founding fathers of epidemiology. There are many more who've contributed in recent days, but he mentioned Jon Snow. And many of you who've seen the famous TV series, The Game of Thrones, will know that name from a different Jon Snow. And the famous line that was accompanied in that series with, "You know nothing, Jon Snow." And Jon Snow, of course, from Dr. Sabin's point of view, the other Jon Snow, he may not have known much at the beginning, but he ran upstream to figure out what was causing cholera in 1854 London. And he was able to think about what no one else has thought. To think about what no one else has thought. That's a profound observation from Professor Liambabage, the Vice Chancellor of the University of Rwanda. And that's exactly what that Jon Snow did. He thought, what is causing these people to be sick? And that is really the detective skill of thinking through things at a time when even the theory of germs was very undefined. And then with the goal, of course, of sharing those findings based on the evidence found in order to solve these complex problems. Today, in light of COVID-19, the significance of strong and resilient health systems has never been clearer. All over the world, we've seen that well-trained and skilled epidemiologists are critical in the response efforts. We all, in some ways, need to put on our thinking caps and become disease detectives. We've all become consumers of the RBC and Ministry of Health's data that they share with us each night. We also know that there's been a lot of progress in tackling persistent problems like tuberculosis, malaria, measles, typhoid, yellow fever, even cholera, and more recent diseases such as HIV/AIDS. In fact, I think the last time I was in this room, Dr. Sabin and I were reflecting was for the ICASA conference in December of 2019. And because of epidemiology, as he said, we're able to come here today and discuss these important developments. We still have work to do. Targeted interventions informed by continuous surveillance and data synthesis remain essential. And as Dr. Simon told us and Dr. Tedros spoke about in Atlanta 2 years ago from the World Health Organization, it is important that there are sufficient field epidemiologic capabilities in every country. That's one of the key foundations of our international health regulations, and that is critical for ensuring global health security. Again, as Dr. Sabin, I believe, mentioned, if you go from a resilient health system, that is a necessary transition to getting to global health security, country by country, place by place. And Rwanda's investment and support of public health workforce development in this field epidemiology training is therefore very strategic. And if I do the math, when you multiply the number of field epidemiologists who've trained or will soon graduate, Rwanda's population is 13 million, and you need one of these epidemiologists for every 200,000 people, then Rwanda is on the cusp of achieving the 65 that are needed for this country. In fact, by the end of this training period in this next 6 cohort, Rwanda will have 75 field epidemiologists trained, and they themselves have spread that to a broader array of field epidemiologists and frontline workers. It is coincidental but important that this month, September 2021, has been designated the World Field Epidemiology Month. This itself is a great global acknowledgement of the role of field epidemiologists in protecting the health of populations and in advancing global health security. And thus, this conference is being conducted at a pivotal time of the COVID-19 pandemic, and yet it allows us the time to pause, reflect on the work of FETP and those field epidemiologists that are all over the country of Rwanda, working to contain this pandemic and many others, whether it's Ebola, hemorrhagic fever, whether it's malaria. This is an all-consuming passion of running upstream to find the solutions to these disease problem sets. As we mark the 10th, or perhaps it's already the 11th anniversary of the launch of the Advanced Rwanda FETP program here, through the contributions of the United States and the partnership with Rwanda, we have seen remarkable increase in Rwanda's national capacity to respond to these sorts of outbreaks, making both Rwanda, and has been said, the entire world much safer. And as I say in Kinyarwanda, ubuzima bwanyu ni ubuzima bwacu, ubuzima bwacu ni ubuzima bwanyu. And for those who don't speak Kinyarwanda, that means that our health is your health is our health. And that's critical to, in fact, that would be the buzzword, I think, of global health security. I commend the Minister of Health, Ministry, and the Minister for the strategic decision to use this resource, the FET graduates, during the COVID-19 response, as well as other outbreaks over the course of recent history since the development of this program. and expanding both the advanced to include the 3-month frontline component is critical. And I hope that soon we'll see, perhaps at the next conference, that there'll be an intermediate program as well. These achievements have been made possible through this collaboration with the United States and other partners to build a sustainable future for the program. No one country or agency can tackle the challenges of public health on its own. But by working together, Turi Kumwe, we harness the resources and leverage a wealth of professional and technical expertise and resources. So therefore, let me take this final opportunity to express my gratitude to all the partners and players who continue to support and nurture FETPs. And that includes here, can I see the hands of the mentors and faculty? Fantastic. Let's give them a round of applause. The Ministry of Health, RBC, University of Rwanda, Ministry of Agriculture, who contributes to the One Health Challenge, and other government of Rwanda agencies. AFANET, the World Health Organization, TEFINET, which is the global agglomeration of all the regional field epidemiology networks. Thank you very much and have a great conference. Thank you.
I want to thank His Excellency the Ambassador. Thank you for doing valuable support, which has made these achievements and many others possible. It is my honor to welcome the Honorable Minister of Health, Dr. Daniel Ngamije, for his remark. Welcome, Honorable.
Your Excellency, U.S. Ambassador, the Vice Chancellor of the University of Rwanda, the CDC Country Director, the Executive Director of African Field Epidemiology Network, AFNET, the Director General of Rwanda Biomedical Center, distinguished participants, ladies and gentlemen, good morning. I'm pleased to welcome you to the second Field Epidemiology Training Program Conference. The event comes at a time that the country and the entire globe is working tirelessly to control COVID-19 pandemic, where the role and contribution of scientific community, especially epidemiologists, field epidemiologists, is extremely important. We have witnessed the tremendous contribution of field epidemiologists in the fight against COVID-19 since the beginning, early 2020, but also before, when the sector faced epidemiological events in the community around the country. You remember the Ebola crisis in the region. The theme of this year's event is building resilient, sustainable, and innovative public health system through field epidemiology training. This theme is much relevant as we are gathered to witness the scientific contribution of Rwanda FLTP resident and graduate. In simple words, we could not track, test, isolate, and treat patients infected with COVID without the support of FLTP graduates. We could not convince decision makers for very tough and painful decisions like lockdown without strong facts and evidence. You FLTP graduates played a key role to gather those facts. This decision contributed to keep our health system resilient and prevented disruption of essential services. The emerging public health threats have highlighted the great demand for epidemiologists, the need to strengthen our health system through capacity building of workforce, both at central and at the centralized level. The Ministry of Health strongly supports capacity building as we strive to build up a solid pool of well-trained frontliners to support the surveillance of disease and promptly respond to any public health emergency. The list of presentation planned for these 2 days reveals the amazing work done by most of researchers in different programs, ranging from malaria, HIV, TB, and others in the field of health security. Ladies and gentlemen, conferences such as this one provide a valuable opportunity for research scientists, scholars, and decision makers to share experience. And I'm grateful to many of experts who have come to share their knowledge, and I'm sure you will have fruitful and rewarding exchange in the next 2 days. I wish to take this opportunity to thank partners who contributed and who still continue to provide technical and funding support for the program. The government of Rwanda is grateful to US Centers for Disease Control and Prevention, CDC, President Emergency for AIDS Relief, PEPFAR, President Malaria Initiative, PMI, United States Agency for International Development, USAID, African Field Epidemiology Network, AFNET, Training Programs in Epidemiology and Public Health Intervention Network, the World Health Organization, for continued collaboration and support since the inception of this program in 2009. I sincerely thank all participants and wish all presenters an excellent week filled with insight and inspiration. I wish you success with this important conference.
I would like you to help me and join me in thanking again our high-level guest today. Thank you very much for taking the time to join us here today, because I think it's a recognition of the importance of this conference. And so as we close this sort of initial part of the day, I would like to request assistance from the protocol. The next session would be a photo session to mark this occasion. And the photo session will take place outside. For the rest of us, for the rest of the participants, there will be a tea break after this. But for this part, after thanking again our high-level guest, the photo session will be happening outside. Protocol will help us and lead the way. And so thank you again for your time. And I realize that as we mark this official opening of the conference, we may have the opportunity to see them again and come and meet with us. But if not, it's just a recognition of your time. So thank you again. Yes, so protocol, if you can show them to the place. I want to also acknowledge special participants that will be joining us and partners. Among them are the Fetp coordinator as well, the CDC Rwanda country director. I think many of you, they'll sort of signal you. For the rest of us, let's just take the next few minutes to get ready. The tea break will be actually on both sides of the room. It will not be long. It will just be around 20 minutes, but just for us to reflect on what we just talked about in this first part of the event. So there'll be mirror stations. A station, yeah, I see they're opening the doors. There are stations to the left of the room, my left, your right, and then to the other side as well. So you can pick whichever one you want. Because we're running slightly, behind time, we had initially thought that by 10:30 we would be done with the tea break, but let's give ourselves the next maybe 20 minutes to stand up, walk around a little bit, grab some coffee, a few snacks, say hello to our colleagues and friends, and then be back in the room in the next 20 minutes. Thank you very much. And on this floor, the restrooms are I believe, on this side of the room, and you just turn to the left and you'll be able to access them. So see you in 20 minutes.
I want to be with you forever. Whenever we're left. Then think about it.
Hello again. Hello again. I want to request some help from the people from both sides to start and make your way back into the room. We're about to start the first plenary. So welcome back into the room. So I think it's time to resume, and we are about to start the first plenary. So let's give ourselves, as good disease detectors and detectives and good people that go and run upstream, we have to be, let's honor the time. So if you can help me bring the people back in from this side as well as the other side. Maybe one good way is to cut off the coffee supply, and then you'll see people coming back.
Working online, I thought of coming here. So really, we've come from far, and that's why I'm saying time flies. And today, as I'll be taking you through this session with at the meeting, we are celebrating some of these successes. And this is just a tip of that iceberg, because a lot has been done. I think we may need several days and even more to be able to elaborate on all that. But we are glad that today we are here to share a little bit of it so that we are able to get motivated by it. So our first presenter is our keynote and it's Dr. Edson Rwagasore. He's the head of epidemic surveillance, preparedness, public health surveillance, and he's also from cohort 4. And this is the desire and the growth services at the stages of resources that makes it to be there, to be where it is now. So give it up for Mr. Edson.
Thank you so much, Dr. Elizabeth. I'd like to have a lesson toward the previous public health surveillance. Public health surveillance. What you've done it's going to be
and you. There's a technical issue.
All right, maybe before we start with the PowerPoint presentation, maybe we can go through and give some highlights on how and where it came from. As all remember when the first state was an experiment. In that period, there was a need for a very strong the pandemic. And also at that time, good fighting fair. So all these underscore the need to have a really the pandemic, I would say, it was one of its kind, and
Yes.
should I continue below the slide? I would have a strong case management team to be able to and also we are also in need a page system, but so this this then has been expected. When you go to the next slide. We have almost 4 phases that we can record started, the pool of people, pool of doctors, pool of different stakeholders were put in place. And with this, right number of people that helped us in responding to this pandemic in the country. So also maybe I should like to flag out that among this pool of people, we have Fetp lessons, alumni who also were part of this process. So next slide. So we cannot all achieve this having a resilient health system without having a financial support. And from this, the government of Rwanda have been supporting the response to we have also support in terms of material supply chain and also incentives to people that are supporting the program. So next slide. So the last pillar and most important is that we did all these all interconnected with the health providers and also the pool of people working together. We are able to maintain the net structure where if you have a snapshot, you can see the snapshot of another care that were recorded during this period from 2019 to 2020. You can see that there was no any significant decrease in number of services that were provided. Also, the family planning services were maintained at the same level. So this really shows that the health system was more resilient to deal with the COVID, but at the same time also deal with others or important infectious and non-infectious diseases. So next. So from here, maybe I'd like to show some challenges that we faced during the process. Also the lesson that we learned during this pandemic and how that fits in within supporting the sustainable and the resilient ecosystem. There's a need to always leverage on existing software. As you can see, during this period when the pandemic started, we leveraged on the response and preparedness that was put in place responding to Ebola within the region. Also, one lesson that we learned is that always we should adapt based on different challenges. So during this period, maybe there are also other kind of innovative approaches that we use in terms of investigation, depending on the specific challenge. Also, the most important part is the use of data and technology to guide decisions. From the beginning, we kept on testing, tracing, but at the same time use data to guide some key interventions and non-administrative interventions. And the last important aspect, there's a need to strengthen decentralized structures and coordination mechanisms to support us within this response. Thank you.
For the great presentation, full of data, and actually that is what we have been served with in every scientific advisory group meeting, all thanks to Edson and the team. And that has really driven a lot of discussions and what interventions to be put forward. Really, this has been a great contribution. So we'll move to the next session, which is question and answer. Do you have any questions, comments for Dr. Edson? Who will be here with us is waiting to answer the questions before it goes back to you. So anyone with a question, you can raise your hand.
Sure.
You mean the, I don't see any hands raised. So it's like it has been so clear to the point and we're still absorbing it. Yeah, so if there is no question yet as of this moment, Dr. Edson is still with us. And even when we are doing the next plenary, if you remember any questions or comments for him, you can still bring it up. But really, thank you so much. We really appreciate it. So we are in the next plenary session, which is on the COVID-19 presentation, and I take us to that.
Thank you, Dr. Edson, for this session. We learned a lot about the strategy to respond to COVID-19 in Rwanda, how our system, our health system was resilient. And thank you, Dr. Elizabeth, for inviting me. So for the on COVID-19, it's Olivier Sekouye. I invite him. Yes, Olivier is the FFT trainer from the fifth cohort of the Rwanda FFP program. He has a medical laboratory background and he currently works in a blood transfusion division in Rwanda Medical Center. He's going to present us risk factors associated with COVID-19 infection among contacts of COVID confirmed cases in Rwanda in 2020. Welcome, Olivier.
Thank you very much. Good morning, everyone. My name is Olivier Sekouye, and I'm happy today to present to you my abstract on factors associated with COVID-19 infection among contacts of confirmed cases
Our mentors. The study is called Investigation of 4 clusters of severe acute respiratory syndrome coronavirus in Rwanda 2020. In late December 2019, COVID-19 was alerted in Wuhan in China. Globally, 4 million cases and 300,000 deaths were reported within 100 days of WHO declaration. WHO Afro region had reported 44,533 cases and 1,425 deaths. The first case of COVID-19 in Rwanda was reported on 14th March 2020. Within the first 40 days, a total of 154 cases of COVID-19 with no death were reported. Other cases in Rwanda were imported. However, community transmission could not be ruled out. This study sought to identify close linkages between among cases and contact and understand transmission chain and patterns. A confirmed case was defined as a person with COVID-19 positive result from laboratory, irrespective of clinical sign and symptom. And the contact was a person in close proximity with a confirmed case in 14 days prior the symptom onset or 3 days prior the sample collection until the isolation of symptomatic patients. Among contact, we classified them into 2 categories. The first one is high-risk contact. There are those who had come into unprotected face-to-face contact or having been in the close environment with a COVID-19 case for more than 15 minutes. And the low-risk contact, and low-risk contact were close were those who had come into contact while wearing a mask or were more than 2 meters away or for less than 15 minutes. Contact tracing was conducted by interviewing confirmed case to information to record information about people who have been in contact with them in the past 14 days. Identified the contact were tested twice. The first test was done after within 24 hours, and the second after completing the follow-up of 14 days if the first case was negative. Social demographic and clinical data on case and contact were collected. The data was collected and summarized using standardized line list, and data crate were calculated. Allow me to present the result. By April 22nd, 2020, in our 4 clusters, we had 40 cases and among them, 4 cases were imported and 36 were locally transmitted, which represented 61% of all locally transmitted cases. This is the illustration of the first cluster, named cluster A. This cluster has 10 cases, and they all linked to the nightclub A. The first 2 cases were imported, and they visited the nightclub A on 11th March 2020. And the contact were identified among employees of that nightclub, and they were tested, and 5 among them were positive. And the investigation continues, and we found also contact among clients of the club, and 3 among them tested positive. The second illustration is for the second cluster, named cluster B. This has 17 cases, and the first, and he visited the nightclub B, and he met 2 persons who became positive after, and one of them, named B8, took the infection to her house, and the house named B8 household. Then the infection spread to other patients from this cluster from B8 household. The third cluster, named the cluster C, also is linked to a house party. The first case was imported, and he went on the house party on 14th March. And among the people who attend the house party, 5 were tested positive. The last one was the only cluster without an imported case. The first case in this cluster was a lady who called on the toll-free number 114 and told the team, the surveillance team, that she developed symptoms, and the intervention team went at her household. They tested her and it became positive. Then all people in her compound were tested, and 4 among them tested positive. 3 were at her house, at her investigation found other people who visited her, and among them 2 also became positive. We calculated the attack rate. This table shows the attack rate in the 4 clusters. The overall attack rate in the 4 clusters was 2.5%. 3.5%, sorry. And the next table is the attack rate among contact according to the type of contact. Among high-risk contact, the attack rate was 10%, and among low risk, the attack rate was 1.5. Next. And this is the table which shows the percentage of cases without COVID-19 symptoms. Among all those 40 cases, 37.5% did not present any symptom. We can conclude by that gathering in a closed space were probably the main drivers of transmission are in the outbreak. And the systematic case investigation, contact tracing, followed by isolation and quarantine, likely contributed to the early successes in containment of COVID-19 in Rwanda. This study provides evidence that supported the Rwanda Joint Task Force for COVID-19 decision to close nightclub and other non-essential gatherings, initiate testing of all contact, including contact of asymptomatic patient, and outline precautionary measures regarding social gathering after lockdown was lifted. We acknowledge the followings, and I can, if you want to know more about this, there is a paper published and found more details on this. Thank you for your kind attention.
The next and last presenter on this session on COVID is Noela Benemaria. She's an environmental health practitioner. She's also a Rwanda FETP alumna from the 5th cohort. During this current COVID-19 pandemic, she supported South Province in IPC. She currently works at Kibagabaga District Hospital. She's going to present predictors on COVID-19 in Southern Province from March to December. Welcome, Noela.
Thank you very much. My name is Noela Benemaria. I'm going to present about the predictors of COVID-19 infection in the Southern Province. As my fellows said, the first case of COVID-19 was identified in Rwanda on 14th March 2020, and Joint Task Force was created, and these included surveillance, contact tracing, lab testing, infection prevention and control, and case management, and so on. And similar structures were established in all 30 districts of Rwanda under the leadership of mayors. Surveillance activities through laboratory investigations have been carried out across the country, and the Southern Province at that time had a high positivity rate, and we conducted a study aimed to characterize and assess the factors associated with this COVID-19 infection in the Southern Province. We used the secondary data analysis during this outbreak investigation. Data were extracted from the electronic system used for registration during laboratory sample collection, and a total of 23,737 samples were analyzed. In this methodology, we analyzed data using logistic regression to measure association of different factors with this COVID-19 infection. The direction and strength of association were expressed using odd ratio and 95% confidence interval. Allow me to present the findings of this analysis. Among these samples analyzed, above 1,000 were COVID-19 positive, and 86% were presumptive positive. The positivity rate at this time in this province was around 5%, and this positivity rate was high in Muhanga at 11.5% and low in Huye at 2.7%. Distinct participants, this is how our cases were distributed in time. This is an epi curve for those who are used with epidemiological curve. And the peak was identified during November. This is how our cases were distributed in time. Next slide. Positive cases, as you see, positive cases by sex, many cases were among male, and by age group, as Dr. Edson said, was among the youngest people. It was between 18 and 44 age group, as you can see on the graph. Next slide. We also identified some clinical characteristics that characterize this COVID-19 infection, and many people had headache, others had cough, and some of them had asthma. But also, let's inform that this data set we used was missing some information, but what we found. Next slide. With the factors associated with COVID-19 infections, we found like living environment or living places, and students and people in rehabilitation centers were more exposed to having COVID-19 infection. You can see that the odd ratio is around 6.5. So this shows us how these people are exposed to having COVID-19 with this p-value and odd ratio. Next slide. The occupation of our study participants showed us that frontline workers were more exposed to having COVID-19. They were around 7 times getting COVID-19 compared with other government staff. Next. We also analyzed these clinical characteristics, and we found that these people with fever were the most likely having this COVID-19 infection. Next. Distinguished participants, this outbreak investigation characterized this COVID-19 in the southern province and showed that occupation, living environment, and having symptoms like fever were associated with COVID. Highlight that frontline workers are to be protected, and preventive measures should be enforced among people living together. We acknowledge the Ministry of Health, the AFNet, the University of Rwanda, FETP mentors for being with us while conducting this outbreak investigation. We thank you. Merci beaucoup. Asante sana.
Another round of applause to our 3 presenters, please. Yeah, so thank you so much for the great presentations on COVID-19, ranging through different topics. Again, it's our time for questions and answer. Any questions for any of the speakers? Question? Okay, there's a question here. Is there someone passing the mic? Oh, and the mic is there.
Hello. Yeah. Thank you very much. Very nice presentations. I had 2 questions. Let me start with the question for Laurent. It shows the importance of doing investigation and informing decision making. I think you presented two nice or implications of your investigation showed the importance of closing the nightclubs. I wonder if you've done similar investigations implicating other public places, such as religious places, churches, markets, and even sporting events, because subsequent measures also implicated those. So that would be a question that I have. And then for Olivier, for his first presentation, I was curious, you mentioned the relationship and you had three categories, I believe, household, neighbors, and others. I wonder how you classified maybe girlfriends, boyfriends, household, sexual context, because I would assume that those are also kind of a high risk factor. How you dealt with those, with that. Thank you.
Thank you so much. Any other question to our speakers? I hope you are capturing the questions so we can number of questions before we start answering. Any other person with a question? As people are still thinking and absorbing, maybe Laurent and Olivier, you can start by answering the questions that have been raised. And I think for the first question, we could even invite other people here to also address, because there could also be other things that might have been done in other public spaces as well. So I'll start with you, Laurent. Okay. He's saying it's okay. Just try, you see.
During our investigation, we didn't target nightclubs. We visited patients and they told us where all the places they have been in the last 14 days. Then we, among those places, we identified, we visited all those places to find how many people they met there. And they told us also the names of people and where they met them. So we identified those nightclubs from the list of places provided by patients. So we didn't focus on nightclub and find if there is happening there. We visit them because they were given by the cases, and we followed all the people they met there. Maybe after this work, the other places were identified. Other public places were identified to be source of transmission, but in our study, we only found nightclubs and house parties. Maybe it's because it was the early epidemics. If today, if you conduct another study, you may find many places. Don't know if
my question was actually following your investigation, which is probably the first. Has RBC or other graduates investigations clusters that implicated markets or sporting events or churches that led then to subsequent public policy implications of shutting those ones down as well? It's maybe more a question towards RBC or fellow graduates if there's other cluster investigations done in Rwanda.
Yeah. So the question is back to the plenary, to RBC. Are there any other investigations that have been done in other public spaces? Because this study, the focus eventually settled on a particular area. I see Edson.
Okay. Thank you so much, Dr. T. Actually, we didn't do any other further studies, but we base on the knowledge that we got from this study. And this was also, we found in different investigation activities that were conducted. As far as I know, there's one that we did in Karongi, where we found a lot of people within the church, and then we tested them. So, this really, just to complement what Laura said, it showed us that closed space are the driving factor for the increase of cases in the country. And that's why most of the interventions that were put in place also encourages to have kind of meetings outside, having restaurants taken outdoor, and also if you have marriage, then you have increased the capacity when it is outdoor. So this was based on this, but also the evolving science behind it. Thank you.
Thank you so much.
Yes, thank you very much. I'll try to answer the question by complementing the three people, the two people that have already touched on this. So as interventions that were conducted during the investigations, I want to point out a few settings that that were closed settings that we also made interventions for. So there were a few clusters that were identified in markets. I think from that, as a result, the three markets within Rwanda, within the Kigali city, were put in lockdown for about 2 weeks, if I recall correctly. And then from that, we also intervened in a cluster in prison settings, whereby about 3 of prison, we identified while doing the contact tracing some of the prisoners that had been transferred from different prison facility to the next. So as a result, we also informed the public health leaders to set measures for correctional facilities, including testing prior to having transfers to the next prison facility, among many other public health measures. So we pretty much had different interventions within different closed settings, prison facilities, markets, schools as well. So I can't list them all, but as time goes by, we also have to highlight these within the next coming findings of the scientific conferences that are about to come. Thank you very much.
Thank you so much. Thank you so much. There's also a hand raised on the other side.
Thank you so much for this opportunity and the presentation that you made. I would like the presenter from Chiwaja Baga Noela, not the name. I would like to know how does she handle the missing value unit system, since she said that she used the data from HMIS. I know most of the time there is so many missing value there. So how does she handling them? The second question is that you said that you have used the data from HMIS also, and the prevalence was seen in Southern province. But most of the time, as I know, in mass testing and the other activity that involves more cases. Most of the cases, the healthcare provider do data entry, but most of the cases they entered positive cases. Then how does you know where this is a real prevalence by district?
Okay. Yeah, so thank you so much. So now we have a question from Olivier, that has not been answered, and we have two for Noela. So Olivier, there was a question about the contacts, and how did you elicit other contacts that maybe someone could be a partner, a sexual partner, but you don't say, it's not a spouse. How did you handle that?
Thank you very much. During this study, we tried to classify contacts based on the relationship with a confirmed case. Like we have presented, we had contacts from the same household, neighbors, and the other contacts that were classified among friends or other relations. But during investigation of a confirmed case, we are focusing mainly on how the case was interacting with his or her contact. So you have seen that we've also said about the risk of exposure. So during investigation, we were trying to ask a confirmed case, how was the risk of exposure with that contact that he has provided. So through that time, we considered contacts as high risk or low risk based on the discussion we had with a confirmed case. Thank you.
Okay, so thank you so much. And now to Noela.
Thank you very much. He asked me how we handle data. And during the presentation, I said that we extracted data from the system that was used by the laboratory while collecting data. Data that was entered was not only for positive cases, but for each individual who was being tested, records were taken. And then the result of the tests were also filled in the system. Now, by extracting this data, we extracted those positive and presumptive, but also during the analysis, we considered all those who were entered in the system. And this brings me to clarify what I presented. This was not a prevalence, but a positivity rate. And this positivity rate was calculated considering these positive cases with all those who were tested, not a prevalence. Thank you very much.
Thank you. Then there was another question. He was talking about, did you encounter issues of missing data, having used HMIS? And how did you handle that? I think that is also an important component.
Yes, thank you very much. And sorry for missing this. With this missing data, we used to, I think those who know this cleaning, to clean the data set, while we were cleaning this data set, we also managed to calculate this rate considering the data that were well completed. So we did internalize using the missing data, but we used the data that were available. And this, I can say that during the analysis, the denominator may change according to the available data in the system. Thank you. I don't know if Olivier can also share his experience as he also used the HMIS.
Yeah.
Okay. Thank you very much. About the data from HMIS, Actually, the completeness sometimes is not 100%. So, as Noera said, we first screen data, and for missing data, we can try to see if it is possible to complete them. But the process of cleaning data is the most important process because it's the first step to just starting performing those analysis. So I think for missing data, sometimes most of the missing data are not really, even though they are important, but during the analysis, you can, during this presentation, we generalize. It's like we sampling for generalization of our results.
Okay. So thank you so much. And I think for that, if you also have any recommendations on how that can be improved on, because again, it improves on our database and we are able to do much more. I think it will be better to link with the relevant people as well on that. Thank you so much, colleagues. I see Adeline is showing me my time is up, but I have one question. And I think I will use the time that Dr. Edson saved because it's the question for Dr. Edson. So I have one question. I remember at the beginning of the outbreak, and most of the times, there were really a lot of issues on cross-border. Like every time we were thinking that we are almost getting to the end. I remember our next peak was, first of all, it was international travelers, then there was cross-border trackers, then there was Rusizi the other time. So I was just wondering, what has been done? Is there anything that could be done about cross-border? And also taking into account that also some of these neighboring counties also have a Fetp program. And if there could be those interactions and see how we work together, both from the ministry and RBC component and from the Fetp program component, so that we are able to collaborate on this as well. Thank you. Yes, yes.
Thank you so much. So I think the cross-border issue has been there and since the beginning. As you all know that even the first few cases were imported through the truck drivers that were coming from the East Africa. And the problem's still there. But now it's kind of shifted to a much more porous movement. And that's a big challenge that we are now facing. Among the solutions that we're working on, we are supporting in enforcement, and actually we have added more booths in different porous borders with the support of Ministry of Local Government to ensure that they limit movement of people, especially when there's a high prevalence in neighbor countries and just avoid kind of spillover from country to country. But I think the most sustainable solution, and that's what we are working on, is to ensure that people within different border line they're vaccinated. So I think the countries now it's their number one priority to vaccinate at least people within the borderline to ensure that they do not get infected and also at least reduce the transmission or importation of cases, especially for people moving using porous borders.
That is the end of our first plenary. I really want to appreciate the presenters. You really gave us an easy time. They were all in time. Nobody exceeded the time. We thought it will be a hard task, but you did really very well. And we really appreciate the splendid work that you have done, because all these are part of what has been informing policy and also the response. So thank you so much. So we will want to release you before we start our next session, which is on health security. Thank you so much. Again, a round of applause. So our next session, now we have again 3 presentations on health security. After that,
there are different topics. After that, we'll have another question and answer session. Thank you so much.
So, the second part of this plenary session is composed of 3 presentations on health security and other outbreaks. Our first speaker is Mugwaneza Denise. Mugwaneza Denise, she's a veterinary doctor and Rwanda FLTP alumna from the 5th cohort. She's currently worked at Rwanda Agriculture Board as a veterinary public health inspector. Her big interest is the control of zoonotic disease through One Health approach. She's going to present us predictors of COVID-19 in Southern Province. Is a study she conducted from March to December 2020. Denise, what is yours?
Thank you for this throw. I'm gonna to present to you my project entitled
While waiting presentation, just a correction. The presentation she's going to provide us is factors associated with inappropriate use of antibiotics among animal health professionals in 5 districts.
Thank you. I honor to present to you my project entitled Factors Associated with Inappropriate Use of Antibiotics Among Animal Professionals in 5 districts of Rwanda. The Sustainable Development Goals, especially on the targets to and fed, engage the increase of animal production. The insufficient or lack of control on antibiotics use, both in human and animal health, lead to antibiotic resistance. The science approved that the misuse of antibiotics can lead to the antibiotic resistance. And the science proved also that the antibiotic resistance transmits from animals to human through food or through environment. And that leads us to think that animal health professionals are indispensable leaders and guide us to contain that issue of antibiotic resistance. The scientific research conducted in Rwanda assessed that there is unnecessary and inadequate use of antibiotics in farms in Rwanda. A little is known on the level of knowledge and the practices of animal health professionals regarding proper use of antibiotic and antibiotic resistance. These projects have the objectives of to determine the level of knowledge of animal health professionals on antibiotics and antibiotics resistance. The second objective was to find out the factors that influence animal health professionals to inappropriate use of antibiotics. During this study, the antibiotics level, either inappropriate or appropriate, was assessed by through measures: the knowledge of animal health professionals, the level of trust of antibiotics, of veterinary antibiotics, which was available on the local market, and the social demographic characteristic of participants. This study was conducted in 5 districts of Rwanda. One district was randomly selected in one province. Our target population was all animal health professionals working in a field in those 5 districts. Structured questionnaire was used during the interview with the participants. Cross-sectional stats was used, and those structured questionnaire was used. What also we called inappropriate use was inappropriate use was defined as using antibiotics for other reason than treatment, or non-compression of required course of antibiotics, or overdose of the drugs during the treatment. One of these defined the inappropriate use, or all of them. The knowledge was assessed by 4 questions. If someone successfully responds to at least 3 questions, was classified as high knowledge. On the other hand, was the low knowledge. Social demographics contained different variables. Level of trust to the quality of veterinary of antibiotics was assessed by asking the participant if we have the trust to the veterinary antibiotics on the market, and they say yes, or low or high, compared to his thinking. The data that we have received was analyzed, the frequencies in the percentage was calculated, logistic regression was used by calculated odds ratio and the confidence interval. The startup version 15 was used during the data analysis. From the findings, you have seen that the people that you have used, 27% was working in the private sector, while in the public, as a public servant, while 73 was private practices. 77 was male, while 22 was female. The mean of their age was 32 years old. The overall of inappropriate use was 68%. The common malpractice that they have done, the malpractice that was used for defining the inappropriate use, you have seen that from the people who have done the overdosing, 67.2% was by thinking that the increase of the quantity of drugs that they provide can give the adequate cure compared to the recommended dose. By prescribing for other reasons than treatment, 71% was provided with the purpose of prevention of disease in the animals. For non-compression of shots, the people think at least 59% because the animals was recovered before they complete the shoot what was recommended. Factors that we have proven that are associated to inappropriate use, we have seen the age, being at the age below or equal to 24 years old was 5 times more likely to make the inappropriate use of antibiotics. The level of trust, people with low trust was 8 times more likely to provide the antibiotics inappropriately. The people with low knowledge was 2 times more likely to provide the antibiotics inappropriately, and also the lack of continuing the education in the last 1 year was proven to be 2 times more likely to inappropriate use. The impact of the level of knowledge among animal professionals was proven to be one of the factors that could influence the inappropriate use of antibiotics in animal professionals. These findings is similar to other studies which is conducted in development countries. As we said, the age was proven to be the part of the factor that could influence the inappropriate use of animal health of antibiotics in the animal health professionals. As we conclude, high level of inappropriate use was found among animal health professionals, and with recommendation, it said that there is a need of continuous education among animal professionals and expanded focus to reflect on the impact they practice on one health and the public health security. Thank you.
Thank you, Noela. The second presenter is group of study on health security and the other outbreaks is Dr. Alexis Manishimwe. He's working at Gisenyi Hospital. He's doing the field epidemiology and the laboratory program. He's in the first year. He's going to present us findings of the study on epidemic typhus outbreak in Muhanga prison. This outbreak was in this prison in December, from December to Feb 2021.
Good morning. Thank you for this time for presentation. Name's Alex Manishimwe. I'm a FETP resident. So I'm going to present about the outbreak of epidemic typhus in Muhanga prison between December 2020 and February 2021. So that's the outline. So epidemic typhus is a louse-borne disease that's transmitted by body louse and head louse. On January 29 this year, Kagai Hospital reported an increased number of February cases from Muhanga prison. So this has triggered an investigation by RBC from February 1 to February 13. So what we basically did, our group of FTP residents, we went on the field to do a post-outbreak evaluation. Next. These were our objectives. So the study was a sectional study. So the primary data source was the registers where we reviewed our cases, suspect cases was anyone with fever or available tests between the period of November 14, 2020 through March 2021. So we also carried out interviews with inmates, clinic staff, and the prison leadership. Also did environment assessment. So the data from registers was collected using Excel sheets, and the cleaning was done with Excel sheets, and the data visualization was done with the Tableau. Next. Results. In total, we identified 1,601 cases, with most of them 99.44 being male. So we also identified that there has been 41 deaths. Our environment assessment found that the wards are overcrowded. So that is the epic curve. You can see that there has been a rise from November through the peak in February, where there was a daily case of 58, and then a tremendous shift, downward shift of the cases throughout. So, next. So this this graph shows description of cases by demographics. So by age groups, you can see that the age group that was mostly affected was the age between 20 and 29 years, but the deaths were more, even if the age over 60 has a relatively lower number of cases, but they had deaths, many deaths. Next. So the information about the wards, the inmates' wards was not available in the registers. So we only found the information in 39.41 percent of cases. So this information was not generalizable. But however, this is how the cases were distributed within the wards. You can see that the ward 10A had more cases. And the information was missing on most of the cases we identified. So next. So our environment assessment, we couldn't identify lice, but we identified that there was not enough water for to facilitate inmates' cleanliness. And we also observed that there is overcrowding. Next. So the team that carried out, the RBC team that carried out the outbreak investigation provided some recommendations, and we, one of our objectives was to evaluate their implementation. So they recommended chemoprophylaxis with oxycycline, and this was done. They recommended fumigation with insecticide, and it was done, and they had already installed a schedule for regular fumigation. So they also recommended awareness of personal hygiene. And they had recommended to increase water supply, and they had added some taps, even if it's not enough. The construction is ongoing. Next. So we had a limitation during our study, so we couldn't find all the data we needed, because it was a retrospective review of registers. For instance, we couldn't find the data about the wards, and so we can't say which wards were more affected, except the fact that most of cases are male, and we can only assume that the being in male wards was associated with high cases. So another problem that is important is that these cases, they are all suspect cases. None of them was confirmed in laboratory. So we didn't have laboratory capabilities to confirm these cases. Next. So in conclusion, so there was an incidence of 24.76 of this outbreak of epidemic typhus, and the case fatality was 2.56. So after the recommendations by the RBC team, there has been observed a decrease in daily cases reported, and we can so we suspect these measures were effective in reduction of cases. So there is still an overcrowding, even if there is will to improve on the reduction of the overcrowding, but there isn't. There is still there isn't a satisfactory level of comfort within the prison. So this predisposes inmates to further possible reinfection. So next. So we have observed that there has been a delay in the reporting of the cases. So we recommend that there has to be a regular analysis of surveillance data to detect outbreaks early. We also recommend that there has to be an improved documentation of the cases within facilities in order to identify cases and the risks associated. We also advocate for the improvement of laboratory capabilities in our country to detect epidemic typhus, but also other rare outbreaks that may occur. Next. So we acknowledge all these partners and other partners we couldn't put on this slide. They have helped us a lot during this post-outbreak evaluation. Thank you.
Thanks, Alex. The last presenter on this part of studies focusing on health security and the other outbreaks is Shimimana Kizito. Kizito is a public health professional. He's currently doing his master's in FLTP in cohort 6. He's working in RBC, in TB and other respiratory disease division. He's going to present the study he conducted, the investigation findings on upsurge of dog bites in Nyagatare district. Welcome.
Thank you. My name is Shimara Kizito. My presence is going to be all about investigating the upsurge of dog bites in Nyagatare district 2021. Next. These are the outlines. Next. Human rabies is fatal infectious, a zoonotic disease of public health concern. Is transmitted to animal, to human by direct contact. And dog's bite is the main risk factor of developing the rabies in human. So despite the effort deployed to control rabies, in a good sense of dog's bite keeps being reported in Nyagatare district. This study aimed to establish the magnitude of dog's bite and describe the patterns of dog's bite in Nyagatare district. Next. The method, a descriptive cross-section study for retrospective analysis was used for 457 in Nyagatare district. Sorry, you're making the presentation. And any person, the dog bite was any person who bitten by domestic and the stray dogs in the Nyagatare district catchment area. And we presented the functions and medical records and reports were reviewed and analyzed with the Excel sheet and the key format interviews with the veterinary officers and the health and sanitation officers in the sector with the high number of cases of dog bites were carried out. Then frequency, proportion, the key quotation were reported as well. Next. The result, next. Distribution of dogs bite case by sex and age groups. As you can see, the more cases were observed in males, which represent 59.5%, when you look at the age group, this graph reveals that the case is higher in the aged group from 10 to 19 with 35%, and 23% was the aged from 0 to 9. Next. And this by social characteristics, this table reveals that the majority of the cases bitten by dogs was found in the category 2 with 63%, and by education level, the majority was observed in those who did the primary school with 71%. By education, please, what is wrong there? Go to the result. Okay. I was saying that in this, by such categories, the day was in category 2, it was 63%, and by education, it was 71% in the primary school level. By occupation, the majority was found in the farmers with the 47%, as well as for 12 for students. Next. And this shows about monthly trend of dogs bite cases. We realized that with this curve, we found that the most cases were reported between October 2019 and January 2021. Next. For incidents related by age group, this table revealed that the incidence it was higher in the under 15 years compared to others with the 105. And by sector, the highest was found in Nyagatare. The instance was found in Nyagatare compared to other sectors. This was followed by Rwanda and Tabagwe. Next. About anti-rabies vaccination that provided to victims, we found that among victims vaccinated, either 81%, only 17% will completed the 5 doses as recommended. Next. And this shows about the life outcomes for those who have been bitten by dogs, and those who have recovered with the residual effect was 65%, and the interview with the community revealed that 5 possible deaths was occurred in the community, but in the hospital we didn't find any cases at all. Next. Regarding findings from interviews with the key informant, we found that Nyagatare district is mainly inhabited by cattle keepers who keeps dogs for security purpose. Domestic dogs are only fed with the corn milk, and they easily get out to look for food. Dogs are almost not vaccinated because with the performance contract at the sector level, they have to vaccinate only 15 dogs per year, so that compared to the total population, there is a low coverage of vaccination. And we found that many wild dogs like Shakal from Akagera, which is natural, the source of the Levis reservoir, are invading the community. Next. And there is a lack of measures in place to prevent and control dogs bite in the community, yet it is alarming. Again, there is a lack of collaboration between the health and sanitation officer and between all the officers, especially in case there is a dog bite. And again, we found that the dog bite surveillance system works in one angle, means that they're limited on reporting, immediately reporting, and the post-exposure prophylaxis, that's all. And again, there is a lack of a clear protocol to manage dogs bite within the state. Conclusion, dog bites is really a major challenge in the Nyagatare district, especially among the most vulnerable population. No clear dog, as the area said, dog prevention control measures like regulation for enforcement in the community in place, and quick and urgent action are needed to mitigate the outbreak using the One Health approach. And we recommend that for those stray dogs and looming dogs in Nyagatare with uncontrolled movement, without control the movements, should be killed, while we don't have the other action, other appropriate measures like rehoming those dogs. And there is, we recommend again, a case control study should be conducted to identify the specific risk factors, and again, to inform the target prevention and the control measures. Close meeting with the district are needed. So here we are acknowledging the following. Thanks.
Yeah, so thank you so much again to our three presenters. We are back to another question and answer session. Anyone with a question, you can raise your hand. We need two people to help us in passing the mic. The first should be in this table. Okay, so this table, then another mic should go to the other end so that we save time. The other end.
Hi, thanks so much for the great presentations. So my first question is to Denise. Yeah, I think very interesting presentation on how antibiotics are not well prescribed or used. So I just wanted to find out whether you checked on any correlation between the training or educational level of the veterinary health workers and the inappropriate use of the antibiotics. And also if there's any correlation between the years of experience since their training and the time when they actually were in practice, when this inappropriate use of antibiotics were reported. So two things really. One is the correlation between the training level or educational level, and two is the years of experience. And then my second question goes to Alexis. So again, thanks for a great presentation on epidemic typhus. So your EPICAV showed a surge in cases between December and February. And I was just wondering whether you found out what the exposure was during that period. Because although in your conclusion you mentioned something about overcrowding in wards and also insufficient water for personal hygiene, but I'm sure this is a persistent thing in prison. So that was probably not something new in December when your EPICAV shows that surge. So just if you could elaborate a little bit on if there's any exposure that was reported around that time that may have contributed to that sharp rise. Thank you.
Thank you. Great presentations. Just a quick follow-up questions. One for Denise. I missed it, but you didn't mention anything on the type of animal. Wonder if you could elaborate on that, if it varies between cattle, chickens, dogs, whatsoever. For Alexis, why is the Muhanga prison different from the other prisons in country? I would assume that you find a lot of overcrowding in other prisons, and wonder if there is any national surveillance system that would pick typhoid up quicker as well. And then my third comment is a comment for Isito on the dog bites. Very important study. I think this is great material for the newly established One Health division in the ministry to pick up, and I really encourage you to present some of your findings to them so that they can put also measures in place, not just in your province, but at the national level as well. Thank you so much.
Any other hand up?
Yeah.
So we can pass the mic as well.
Thank you.
Okay.
My name is Francois Mbonyishuti. So my comment goes to Dr. Noela for his presentation, for her presentation. First of all, I would like to highlight my interest for his topic and congratulate him for making this happen in this conference. So I remember his study concluded with a high level of inappropriate use of antibiotics in the field of animal health. And then I would like to ask her and to the panel, how can we advocate for a policy action considering the economic perspective behind antimicrobial use in animal health? And beside the economic perspective, I also want to highlight that there is also an increased burden of disease from this consideration. So I would also like to attract our attention on the following. How should we predict the impact from the linkage between antibiotic use in animal health and human medicine? And for human medicine here, we need to particularly think globally in the context of global health or One Health, where we are eating vegetable from garden in contact with those animals, where we are using water, which has been in contact with those antibiotics. We are eating milk, we are eating meat, and we are arriving in the same environment with those animals which are in contact with a high level of antibiotics. So we may need to predict or to foresee what will be the impact. I know there are many studies focusing on this, but what if we specialize it and contextualize it in the context of Rwanda or in the context of low and middle income country? Thank you very much.
Thank you. The question there?
Yeah, thank you. My name is Judith Mukamurigo from School of Public Health, CMHS. I think I have a response. Take resistance, and I saw that the needs have already present in the background that the antibiotics resistance could be transmitted from animals to human. So my question was to know how that could be done. And my second was about also the experience of veterinary as factors responsible risk factors that could be also influence the inappropriate use. So I think you can just respond on that. Thank you.
Okay. Thank you so much.
I think I
My name is Dr. Abdallah. I'm the director of Rwanda Provincial Hospital. My question goes to Alexis, but also some of the team members here can help in answering that question. I've seen that you went to prison to do data collection, and actually you consulted the medical files of the prisoners who came to the hospital of Kawai. And in research and in the ethics, data from the prisoners are the data that somehow are ethically protected. So I have this kind of challenging question saying, in case you have a pandemic or an epidemic, how do you engage the balance between ethical considerations and the dangers of the pandemic? I'm bringing this as a good clinical practice, the challenges of research. I have seen in COVID-19, people are taking samples. Sometimes when you are positive, they will do the variant detection without people consenting for that. So my question is, how do you balance the issues of ethical considerations, the good clinical practice, and the dangers of the pandemic? Maybe someone can help, but I know to do the study in prison is somehow not ethically acceptable, and to use those data not ethically nice, but we have the pandemic there, we have the epidemic. How do you balance that? That's my question. Thank you.
Okay, thank you so much. So we have two more, then now we can let the panelists answer the questions.
Thank you. My name is Jean. I'm from Kabgai Hospital. I would like to ask Kizito, I didn't catch well about the prevalence of rabies among those who has been bitten by the dogs. As you saw that men dogs are not vaccinated. And I'd like to hear from your observation during your study, why those with low education level and with low income category 2 are more affected, have been more bitten by the dogs. Thank you.
Thank you so much. There.
I'm Innocent Zavahimana from Ministry of Health. I have two questions. The first, the outbreak of typhus in the prison. When you found the title, you can say that it is a confirmed outbreak. However, no mention of this outbreak. So I would like to ask him, which factors have you based on to confirm that it is an outbreak of typhus? The second one is addressed to Denise regarding inappropriate use of antibiotics in animals. I would like to ask her if it has been managed to assess which kind or types of antibiotics which are misused. Thank you.
Thank you so much. We are okay. Let's take one last question because of time, so that they can respond. I can. Okay.
Thank you very much. I'm Jed Nambara from Nyagatare, but my question is goes to the last presenter who presented us dog bite or rabies. I have seen that the case study from this Nyagatare District Hospital, but you forget to include Gatunda District Hospital also. But sometimes all that the result couldn't to present all district because we don't include this hospital also. Thank you.
Okay, thank you so much for all the questions. These have been interesting presentations with interesting questions. So as you respond, all of you, I've seen you have very good recommendations that some of them really need urgent action. I would really like to know also as you are responding, Has there been any steps towards following up on recommendations with the relevant departments so that it just doesn't end as a study? We also see from the study to action. Thank you. So we will start. There are really many questions. I hope you've captured all of them. So we'll start with Denise. You can respond to all the questions that have been asked.
Regarding on years of experience and the education level, if there's no linkage or the connection with inappropriate use of antibiotics among animal professionals, we have assessed that and we saw that there is no significant difference looking on years of experience about education towards or continuing education. People are asked if they have received any continuing education in the last 1 year related to antibiotics or antibiotic resistance. The second one was if we was assessed if animals professionals on field specialists either in chickens or pigs or in large industries, there is no difference. We have found that the animals professionals in Rwanda, in the context of Rwanda, people on field actually work in different sites. They work what is available on field. There is no specific system, and you say someone is specialized in the industry of pig, in piggery or in poultry. People treat the animals which is available, not considering that someone is in specialized in industry, in a specific industry. It is very rare in this ground of Rwanda. The third one was how we can make the advocacy with the issue of antibiotic, antimicrobial use in the context of developing countries, looking on the economic perspective. This is the starting point. I can say if you can find out this issue and we make the advocacy, it starts with this. The people are aware of that. My institution, Rwanda Agriculture Board, have communicated to on this issue. They say that we have proven that the people are misusing the antibiotics, which can lead the long threat to public health. So I think with a lot of research and the facts and the reality on field, the things might change. And remember that we have now the One Health policy, we have One Health strategic plan, which revealed on this. I think with all those strategies, we can respond to the issue. The fourth one was looking on the prediction. If the people with the high level of misusing of antibiotics in animals, what we can predict for as the impact on the public, the general public health. I can predict if it continue like that without the strategy by containing, it will be worse. I predict if to continue, but I think it will not be like that. I predict the things will be more worse, and will be some people go on the hospital with the infection what was previously able to be treated, and people will die as previous. losing the battle. We see previously the discovery of antibiotics, the more people was died, but with the discovery of antibiotics, people was changed and the death was reduced compared to the previous. But if we go back with the lose of the capacity of antibiotics for treatment, it will be worse. But I believe that our leaders and the authorities will make we make some decision that we respond to for containing the issue of antibiotic resistance. The fifth is about the transmission of antibiotic through environment and the animal food. This is the scientific quotes. The antibiotics, if it is antibiotics resistance, it is developed in animals and you consume the bacteria or the infectious agents that you will get, that you will eat, will be able to transmit it to you if I kind the ability or the antibiotic resistance to you, and the next time if you meet the infection, you will not be able to be treated by the antibiotics what was resistant to the animals that you have consumed. The last one, there is which antibiotics which are inappropriately used in the field. With that, I can't confirm this because there is a need of further studies on the antibiotic resistance in animals, but with observation, people are using antibiotics with large spectrum. They use the antibiotics only targeting to see if the animal can be recovered without consider the long-term problem of antibiotic resistance. Thank you.
Wow, thank you so much, Denise. Those were so many questions, but you've addressed them really well. So we move to the next. Alexis, you also have some questions for you.
Thank you. Thanks for the people who asked these questions. They really showed me that they have followed. And please stop me whenever you feel you are not convinced with the answers I'm providing. The first question is about the surge of cases in between December 2020 and February 2021 and the potential exposures. So we really didn't go deep because it wasn't part of our objectives, but we inquired about what happened differently, and we got some answers from the clinic staff that they are aware regulations, COVID restrictions within prisons, restricting visits, and so inmates were not getting close to change. And they also observed that most of cases were from the people, the newcomers who come straight from the transit detention centers, also coming with low level of cleanliness. So I really can't confirm the exposures, but these are the hypotheses. So the second question was the comparison of Mahanga prison with other prisons. Really, I can't know. We just went in Mahanga prison. We can't know the situation in other prisons. And as you can imagine, the it's not easy to access that kind of data and to share them if they don't fit the purpose of the study. So about the ethical considerations during data collection, yeah, this is an important question, but we also have to balance the need to collect data, to analyze surveillance data, to guide public health action, because in other population. So interestingly, the Rwanda Correctional Services was very cooperative, and they have granted us access to the premises and to the data access, and we promised and we intend to abide by the rules, the ethical considerations of data privacy. The factors to there's another question, the last one, I guess, about what we based on to confirm the outbreak of epidemic typhus. So as we mentioned in it earlier, there was never a confirmation of any epidemic typhus case, but based on the risk factors, because the primary investigation identified the lice, and there was that low level of cleanliness. And lice are the effectors of epidemic typhus. And the clinical presentation were in favor of epidemic typhus. So this wasn't the first outbreak of epidemic typhus observed in Rwanda or the world. So we have had previous outbreaks. So we still suspect, we still have no confirmation it was epidemic typhus, but we are, based on those risk factors and these clinical presentations, we think it is.
Thank you. Thank you so much, Alexis, for the elaborate responses. Again, there is one important question that maybe may go back to the plenary, either it could be you or somebody else. There was a question also on whether we have systems for systematically detecting typhoid. Do we have surveillance systems for that? So I think it could go back to the plenary or to him. So, Kizito, you can be addressing your questions.
I have a question to be addressed to Kizito. I have a question to be addressed to Kizito from the recommendation you provided. You said there is a need of killing of roaming dogs and stray dogs. I want to hear from you. How do you see the sustainability of killing the roaming dogs and the stray dogs? And you said that there is dogs that live in the farm without fencing. Don't you think that the dogs will also reproduce and there will be the development of new stray dogs and the roaming dogs? How do you think about the sustainability?
Thank you. Thank you. Let's start by this one. Really, killing the dogs is not sustainable for holding the dogs. As I said, while we are waiting to put together the measures like spaying, castration for the dogs to control the reproduction of dogs, these are measures that can put in place. We have seen that if we may combine those, while we combine those measures like vetting dogs, keeping them during the day at home with the, at home, belt and try to food them. But mostly the dogs surrounding the Nyagatare district, they get few food so that they go out to found to look for food. So, as you said, the killing, I'm saying, while we're waiting, there is a strategy to rehoming those stray dogs and roaming dogs at home, but it's not yet put in place. That's we are calling to One Health approach to sit with the Arab and others involved to control those problems for sustaining the strategy. But seeing that we are facing the problem in the community, the community has beaten, there is no enforcement, there is no regulation. We are just suggesting to a little bit just control those movement by thinking while we are waiting for a long time the good result of that. There is a question asked about prevalence. For this, we are looking for investigating the recrudescence of the cases in the Nyagatare district, so that we go to calculate the incidence that which show 9.8 for 10 as incidence, and the question again asked about the social category which is more affected, those who are in the category 2. Put the reason, I think there is more interaction, as we said, formation. I've seen they get the dogs because there is a problem of security. There is something stolen. Those who are in the low category, they go and they interact. They don't know to control. Have to conduct a case control for mitigating, and they understand well the reason behind. When we come, there is some occasion asked for Gatunda. The Gatunda Hospital is a new hospital. We started showing the data from 2018. Gatunda was not yet in place, so that more cases were transferred to the district hospital. There is where we found the all cases, and those who are suspected in Gatunda, they was transferred for looking for the vaccine. Thank you.
Thank you so much. And maybe lastly, I think Edson will address one of the questions briefly, then we conclude the session.
Yeah, thank you so much, Doctor. Syndromic surveillance should be complemented with the data from lab. And I think that's where we have been lagging. I think with the good collaborative work with our partners, we have been shipping some of the samples. And also, as we are also building capacity of our lab to ensure that we have this capacity to at least test diseases such as typhus. And maybe also echoing to what about the need of to be waiver for research and use of data. When we're having a public health emergency, and there's always a need to use data for intervention. And I think that is already waived for specifically for interventions. And when we need to publish, then we can go a step ahead and request for that waiver from Rwanda Medical Ethical Committee. But this always is for the benefit of the country, for the security, and yeah, thank you.
Okay, so thank you so much to the presenters of this session and for the entire plenary session that we've had. So I can release you. Give them another round of applause. So we really appreciate you. And as we said, it's a tip of the iceberg. Another tip of the iceberg will be outside in the poster presentation. So I think during that time, you should also go to see much more. Really, this has been very informative. And we believe that following this, there'll be follow-up on recommendations. There will be much more work to be done. From the questions that were coming up, it's also showing how there's still so much that can come out as a result of this. And one last thing, I think just to allude to what Edson said, really having data systems is key. I think this COVID is like data was every day, like it guides the leader, it's the leaders, it guides everybody. And I remember someday I was talking to a colleague and we were saying like if we were to do this again, you know, sometimes we will see it focus on elaborate plans. The data part comes at the tail end, like how will we collect the data, which tools, what is the reporting? And I know the data teams that are inside here know how far we've come from, you know, starting from where keeping on updating and improving. And I know that what has been built up to now, as you said, learning from this pandemic, we can also use that to have in mind for the future and also to build the resilient systems that we are talking about. And for the workforce, again, another important part, I remember along the way, frontline trainings also had to be done, incorporating COVID, because now there was a need for much more teams outside doing all this. So really, we really appreciate, and we are hoping that we'll keep working together, and also the leadership that has been reflected in this, we really appreciate. Thank you so much to now it is lunchtime. Lunch is ready. Thank you so much.
We will take lunch in Radisson Blue in another restaurant. And the session for this afternoon will start at 2:30. So we invite you to try to respect time. Thank you.